Welcome to Thrive with Pride from Age Options, an online space for LGBT+ older adults and those who care for them. This is a recording of a live event held on Zoom, which included a Q&A segment that was not recorded. This month, we welcomed Maddie Kutler, Karen Williams, and Dr. Danielle Larson from the Michael J. Fox Foundation to discuss what Parkinson's disease is, how it impacts the LGBT+ community, and why research participation is so important. Please see the video description below for a PDF of their slides presented in the recording and other helpful resources. All right, so welcome to May's Thrive with Pride event. We've got some wonderful presenters coming to us from the Michael J. Fox Foundation that is dedicated to finding a cure for Parkinson's disease for the 6 million people worldwide living with Parkinson's. We've got three great presenters today, Maddie, Karen, and Dr. Larson. So I'm going to go ahead and read their bios now so you know who's speaking for us today. So Maddie joined the Michael J. Fox Foundation for Parkinson's research in 2021. In their current role on the patient engagement team, Maddie supports recruitment and retention for MJFF's flagship natural history study, the Parkinson's Progression Markers Initiative, or PPMI. They are also responsible for several diversity, equity, and inclusion community engagement projects to help with the study's goal of increasing the number of participants from historically underrepresented communities. Maddie is a member of the Foundation's LGBTQ+ employee resource group. Maddie graduated from the University of Southern California with a BA in psychology and a BA in French. Their educational background is in LGBTQ+ public and mental health and French post-colonialism. We'll also hear from Karen Williams, a senior clinical research associate at Northwestern University, Parkinson's Disease and Movement Disorders Center. She has greater than 25 years of experience in clinical research, of which 19 years have been dedicated to Parkinson's research. She serves on several of the Parkinson's study group committees, the MJFF PPMI Study Coordinators Council, the Parkinson's Foundation SIG Institute on Learning, and on a number of community outreach committees. As a native Chicagoan, she is passionate about increasing awareness of PD research in the Chicagoland area, especially to underrepresented populations. And last but certainly not least, we'll hear from Dr. Danielle Larson, a movement disorder specialist at Northwestern. She completed her residency and fellowship training at Northwestern after completing medical school at Tufts University. She is passionate about increasing the awareness of Parkinson's disease in underrepresented communities and increasing enrollment into clinical trials. In addition to seeing Parkinson's patients in clinic, she works as an investigator on PD clinical research studies. All right, so without further ado, I'm going to go ahead and mute myself. We will turn over the floor to Maddie, Karen, and Dr. Larson. Thank you so much for joining us this month.
Thanks, Nina. Hi, everybody. Very excited to be here and chat with you all about what Parkinson's disease is and how it affects the LGBT community, and also how we can get involved in clinical research. So just to give you a bit more information on the Michael J. Fox Foundation, it was founded in 2000 by Michael J. Fox, who has Parkinson's disease. And we're the largest nonprofit funder of Parkinson's disease research in the world. We funded over $1.5 billion of research to date. We aspire to go out of business by finding a cure for Parkinson's. And we maintain a very patient-centered focus, which means that patients remain at the center of a lot of our decision-making. We have a lot of patient councils that help with advancing moves that we make at the foundation. And we always take that patient voice into account. And our mission overall is to advance Parkinson's cures and better care for everybody. And I'll pass it over to Dr. Larson for this bit.
Hey. Hi, everyone. I also wanted to say thank you for joining today to hear about this very important topic. So I'm going to discuss what is Parkinson's disease, what does it look like, how does it affect people? And before I do that, I want to stress just how common Parkinson's disease is. So more than 6 million people worldwide live with Parkinson's, and this makes it the second most common neurodegenerative brain disease after Alzheimer's disease. And what that means in a little more easy to understand numbers is that 1 in 100 people over the age of 60 have Parkinson's disease, though some can be diagnosed before the age of 60. But what that means is that most people, once they're 60 or older, know somebody with Parkinson's, a family member, a friend, or more than one people with Parkinson's disease. So it really affects everybody in some way. And it's important to know that Parkinson's disease is a unique condition for each person that it affects. I'll talk about the signs and symptoms, but it's important to keep in mind that everybody is a little bit different with what signs and symptoms they have and how it affects their day-to-day. Next slide, please. So what is Parkinson's disease? What does it mean for the people that are diagnosed with Parkinson's? So Parkinson's disease is really characterized by its main motor symptoms. And these are the symptoms that are the most prominent, the most obvious, and how we as neurologists can diagnose Parkinson's disease based on doing an examination and finding these symptoms or signs on our neurologic examination. So there are 4 main signs, motor signs. The first is what we call slowness of movement or bradykinesia. And how this can manifest for somebody is that they start to notice that they're just slower in everything they do. Getting dressed in the morning is slower, buttoning up that button, putting on that jewelry, getting their watch clasped. It takes longer than it used to. Day-to-day chores like folding become effortful. And some people think that this is just a sign of getting older or slowing down. But it's actually, when it's part of Parkinson's, it's not. It's not just normal aging, it's beyond that. Another sign and symptom is what we call rigidity or muscle stiffness. So this is something that we test for on our neurologic exam, by we can actually feel an increase in someone's muscle tone. But what this means for people day to day is that they can actually feel stiffness in their body. So Parkinson's disease starts on one side of the body. So what someone might notice is that with their right arm or their left arm, when they're putting on that shirt or their jacket, it feels really stiff and kind of awkward to get that one arm into the sleeve. Or they might feel stiffness up into their shoulder. And that can cause pain. Sometimes people can even develop a frozen shoulder because their arm is stiff and it's not really moving as much. Also with walking, people might not swing one arm as much as the other. And that can be a really early sign of Parkinson's disease. A third main motor symptom of Parkinson's is walking changes, or what we call gait changes. So this is what we typically think of as the classic Parkinson's shuffle, where people start walking slower, they take smaller steps, they don't clear the ground as much when they're walking, right? They're not taking these big steps, so it sounds like a shuffle as their feet are kind of scuffing the ground. And patients recognize this, but usually it's more loved ones or friends or family that notice this, that they're going for a walk and that person just isn't keeping up like they used to. And this can also manifest as trouble with balance or people feeling off balance. And at first this can just feel like, oh, I don't feel quite as steady, but eventually this can lead to falls. And then a fourth motor symptom of Parkinson's disease is the classic resting tremor. So a resting tremor is a tremor that happens when the body is at rest. And the most common in Parkinson's disease is it starts in the hand, and it starts on one side of the body first. So usually someone will notice it when they're watching TV and their hand is just in their lap, or even if they're driving and their hand's kind of resting on the steering wheel momentarily, they can see it shaking. And it's important to know that not everybody with Parkinson's disease actually has the resting tremor. So most people do, but they might not have it at the beginning. They might develop it later in the condition, but there are some people that never get the resting tremor. So this is important to know, because if a person or is noticing in themselves like the other signs, or noticing in a friend or family member the other signs, it doesn't mean it's not Parkinson's if you don't see any shaking. It could still be Parkinson's. And then another thing we want to highlight today is that there are other symptoms beyond the motor symptoms of Parkinson's disease. So we're learning a lot more about what we call non-motor symptoms, because they are less recognized than the motor symptoms of Parkinson's. But these are just as important because they can affect people's day-to-day and they can affect their quality of life. Common non-motor symptoms are changes in memory and thinking. People can have psychiatric symptoms such as depression or anxiety, even if they did not have any of those symptoms before they were diagnosed with Parkinson's. Parkinson's disease affects the GI symptom, and it slows things down. So people commonly experience constipation or other digestive issues. And another common area that's affected is sleep. And this can include REM behavior disorder, which I will talk about, but also other sleep conditions such as insomnia. Next slide. So now that we kind of have a better understanding of what Parkinson's disease looks like and how it affects people, an important thing to know is who is at risk for Parkinson's disease. So we don't know, in most cases, we don't know what causes Parkinson's disease. And there is no single known cause for Parkinson's disease. But there are some factors that can put certain people at a higher risk than others for developing the disease. Having one or more of these risk factors does not mean that person is necessarily guaranteed to have Parkinson's, but we know that it does put them at a higher risk. So some of those risk factors for Parkinson's include decrease in sense of smell or a loss of sense of smell. Most people describe this as not being able to smell as good as they used to. The sleep condition, REM sleep behavior disorder, which I mentioned, is a very well-known risk factor for Parkinson's. And what this is when people talk in their sleep or actually act out their dreams by punching or kicking, doing whatever they think they're doing in their sleep. Other risk factors can be related to genes or genetic inheritance. For example, having a first-degree family member with Parkinson's disease increases your risk, or having genetic testing and know that you carry a gene that has been linked to Parkinson's disease. Other environmental exposures include serving in the military or potentially being exposed to environmental toxins, such as growing up on a farm with a lot of pesticides or drinking well water and things like that that are more unique and pretty specific. And then we know that the prevalence of Parkinson's disease just increases with older age. So beyond 60 years and above increases the risk of Parkinson's disease. And like I said before, it's important to know that having one or more of these risk factors doesn't mean that Parkinson's disease is a guarantee, but it means that it's something to pay close attention for potential signs and symptoms of the condition.
Thanks, Dr. Larson. So now that we have a bit of a primer on what Parkinson's disease is, we can talk a bit more about how it impacts the LGBT population. The short answer is that we don't have a lot of information given the lack of research on this topic. But we do know that the LGBT plus community's Parkinson's-related health and care disparities, including gaps in research, healthcare access, and comprehensiveness, and providers' education have been very under-researched. There's currently no reliable quality measures to tell how many LGBT plus folks are living with Parkinson's. We think there are around 30,000 because there are around 3 million people over the age of 50 in the US who are LGBT plus. And as Dr. Larson said, Parkinson's affects about 1 in every 100 people in this age range. So we can estimate that there's around 30,000 Americans, LGBT plus Americans with PD, but again, it's a complete guesstimation. The LGBT plus population experiences higher rates of depression, anxiety, and isolation compared to the general population. And these are also symptoms of having Parkinson's, making them even more heightened in LGBT plus folks with Parkinson's. People with Parkinson's often self-isolate due to intrusive symptoms, and social isolation is a serious issue for many members of this community, especially those living with PD. LGBT plus people are more likely to be estranged or disconnected from their family, and elders are 2 times more likely to be single and live alone, and 4 times less likely to have children. So there's less of a support structure there. And the figure at the bottom of the slide shows the impact of certain factors on their pro-PD score, which is a measure of quality of life for people with a PD diagnosis. And self-isolation factors like loneliness have a negative impact on quality of life, while maintaining friendships and managing stress has a positive impact. There are also some fears about attending PD support groups that don't explicitly welcome LGBT plus people, because LGBT plus specific PD support groups are very rare. LGBT plus people also experience inequities in their healthcare experiences. Many might choose to delay interactions with healthcare professionals as the result of past trauma within the medical establishment. And for people who are living with PD, early and frequent medical care has really significant health benefits. The earlier a person receives an accurate diagnosis, the earlier they have access to treatment that can really improve the outcome of their disease and result in a better quality of life. 33% of older members of the LGBT plus community have reported experiencing stigma from their doctor, which led to a general mistrust of the medical system, which contributes to less access to medical care for people in the community with PD. So now to talk a bit more specifically about how PD impacts the transgender community. Transgender people are more likely than the LGBT plus community as a whole to experience mistreatment by health professionals. Around 50% have reported being previously mistreated by medical providers. Also, Parkinson's symptoms, such as having a soft voice and stooped posture, or even having surgical treatments such as deep brain stimulation, might affect self-perception and cause gender dysphoria. And also, while establishing Parkinson's care, trans people might, in the meantime, have need for other necessary care, such as gender affirmation treatments and vocal therapies. And a Parkinson's doctor might not necessarily be aware of these needs and might not be familiar with identifying the multidisciplinary care resources that the patient needs. Also, an interesting point is that the role of hormones in PD is unclear. At this point, testosterone has not been found to have an effect on Parkinson's symptoms, but the influence of estrogen remains inconclusive. In cisgender women, which means women whose gender corresponds with their birth sex, research has shown that estrogen can play a protective role, such as lessening certain symptoms. However, there's also a conflicting study that has shown that cisgender women with PD could have more motor fluctuations than men, which sort of challenges that idea of estrogen's protective effect. There is one case study, though, where a 53-year-old cisgender male with PD underwent estrogen therapy, and his medication was reduced by 35% over 3 months, which really improved his motor symptoms and dyskinesias. Therefore, estrogen therapy could have therapeutic potential, but there's really not a lot of research done on that yet. So what does Parkinson's research participation look like in the LGBT plus community? Movement disorders is one of the least researched areas in the LGBT plus neuroscience field, and there are currently no quantitative studies that have investigated primary movement disorders in this community, meaning there are some studies that have looked at more lived experiences and are more interview-based, but no studies that have really collected a lot of numbers and data. Most LGBT plus health research in movement disorders only focuses on symptoms associated with HIV and AIDS. Also, routinely collecting sexual orientation and gender identity data, also known as SOGI data, is really essential to ensuring the delivery and evaluation of high quality and patient-centered care for this community. And without the collection of SOGI data, LGBT plus people will remain invisible, and the burden of disease, bereavement, and other outcomes they experience might go unnoticed and unaddressed. And LGBT plus disparities can really start to be reduced if providers know who among their patients are LGBT plus. An example of SOGI questions that might be asked in research, by the way, is in the figure on the right. There are really few studies that collect SOGI data, and even fewer within the movement disorders field. Previous studies have often collapsed sexual and gender minorities into a single group due to small sample size, which underscores the need for more innovative recruitment approaches and education approaches. But it is a growing number, which is really exciting, and PPMI, which is a study that I work on, does collect SOGI data, and a lot of interesting findings are coming out of that. In addition to studies not collecting SOGI data and therefore not allowing participants to really self-identify, LGBT plus individuals also experience some other barriers to participating in research studies. One of which is logistical barriers, so maybe not having transportation to and from the research site or not being able to get time off of work. There's also historical mistrust. Participants question researchers' motives and express frustration that neither they nor their community typically benefit from participation in a meaningful way. And a lot of the time, data from research studies don't get shared back with participants, so they're really unable to see the impact of their work. There's also a history of judgment and discrimination, which results in marginalization of LGBT plus individuals, which in turn engenders more suspicion towards government institutions and researchers and also health providers. There's very legitimate fears of being outed from privacy issues and research not being anonymous enough in the past. And researchers often lack cultural competence. LGBT plus individuals are more likely to trust researchers who evidence knowledge and sensitivity about the community, which is commonly understood to be a component of cultural competence. And the figure on the right shows how LGBT plus individuals are more likely to have negative experiences with their healthcare providers. But despite all of these barriers that I just listed, research participation is really key to ending health disparities among the LGBT plus community. And I'll pass it off to Karen to talk a bit more about research participation.
Sorry about that.
That's okay.
Good morning, everyone. I want to echo the previous speakers. Thank you so much for taking your time out to hear our presentation. We greatly appreciate your time and effort in sharing our information with you. So why should you participate in research? That's a major question that everyone asks when presented with informed consent or a study. The lack of diversity among research participants has serious ethical and research consequences. This includes impeding our ability to generalize study results, make medical advancements of effective therapies, and it prevents some populations from experiencing the benefits of research innovations and a high receipt of high quality care. As Maddie mentioned earlier, LGBT plus inclusive research is important to expand the knowledge base related to aging as an LGBT plus person. We have so little information on LGBT plus health experience. Increased voluntary research participation is the only way to bridge this gap in knowledge. The figure on the screen shows that the U.S. public health data and monitoring systems collect between 2015 and 2018, only 5.9% of US-based public health data and monitoring systems reported collected SOGI data 2015 to 2018. Most systems collect data only on age, sex, and race ethnicity, and that is only 60.8%. That's interesting information there. So how is Michael J. Fox working towards more equitable research? The MJFF is funding research to advance global relevant understanding of the disease, understand and address barriers to research participation, understand health and healthcare disparities. They are embarking on a major study, as you see on the flyer here, for Pride in Parkinson's disease. I'm sure after the end of this particular presentation, we will share that flyer so that you'll have more information on being a part of a major study. Another study that was mentioned is the Parkinson's Progressive Markers Initiative, which is PPMI. I have been working on this study for approximately 13 years, and it is a phenomenal study. It's a landmark study to define Parkinson's risk, onset, and progression. As you heard the signs and symptoms from Dr. Larson, what we would like to do is look at the natural history. We're studying the natural history to identify markers of progression for use in clinical trials. We're collecting data and biosamples meaning blood samples, from participants for over 5 years. We have patients, participants as I call them, in this study who have been in the study for over 13 years. So that tells you how committed our participants are and how serious that everyone wants to see if we can help find a cure. In addition, we're enrolling 4,000 volunteers at 50 plus global sites in 12 countries. We're enrolling participants for the online. So if you don't want to go into an actual medical center, we have it online, and we have remote data collection and stage risk screening. All information is de-identified and open access for the research community to see our data. So there's something for everyone in PPMI, and you can find your PPMI starting point if you go to the Michael J. Fox website.org/PPMI. We're looking for participants who are recently diagnosed, within 2 years, and not currently on any Parkinson's medication. Patients age 60 plus without Parkinson's disease. As Dr. Larson informed you, that at sometimes age is a risk factor for Parkinson's disease. So is smell loss. So we're looking for patients on that who take a smell test. It's like a scratch off test, and that is mailed back into the center. And if you fail the smell test, you will be connected to a site to participate in the PPMI study. So if you're in the Chicagoland area, your site will be Northwestern. And also we're looking for patients who act out their dreams, as Dr. Larson also mentioned, people who fight or act out in their sleep, where they punch, kick, yell. That is too, as we call it, could be an early precursor sign. And anyone age 18, over 18 in the US can participate without having Parkinson's disease. And we refer to those participants as healthy controls. We compare those to our PD patients, as Dr. Larson said, that some of the symptoms could be due to aging. So we look at that and could do comparisons. So how do you learn more and get involved? To learn more about Parkinson's disease, you can download Parkinson's 360, and that's a guide for navigating Parkinson's disease. You can find a movement disorder specialist, a person like Dr. Larson. You can download Navigating Clinical Trials, and that's a guide for Parkinson's patients and their families. You can participate in research. You can join the PPMI study at any time if you go to the michaeljfox.org website and / as previously mentioned, the PPMI study. You can take the smell test, and the link is mysmelltest.org/pride. And join the Pride PD study, and the link is rainbowsofaging.org, Parkinson's-research with inclusion-diversity-equity. And these links are also on the Michael J. Fox website. And you can browse, as we said, other research opportunities on the Fox website, Trial Finder. And thank you for listening to our presentation, and I'll turn it back over to Maddie.
Yeah, thanks everybody.
Thanks again to Maddie, Karen, and Dr. Larson for joining us this month. Don't forget to see the video description below for slides from their presentation, information on how to get involved in the research, and a brief survey. We hope that you will join us again next month on June 27th for a special Pride Month discussion, moderated by Age Options, new Aging with Pride program specialist, yours truly. This event will not be recorded. Sign up for email reminders of future events at www.thrivingwithpride.org. And again, please don't forget to fill out our survey so that we can continue to provide and improve our programming. Thanks for watching.